Welcome to Colorectal Surgery Podcast. Because every colon tells a story, and every story matters.
Welcome back to the Deep Dive, where we take the densest research, cut through the noise, and hand you the precise signal you need. Today, we are getting into a really high-stakes debate in surgical oncology. We're looking at the optimal way to perform a curative operation for colon cancer, and specifically, we're tackling the 10-centimeter rule, a crucial measurement that determines exactly how much bowel a surgeon needs to remove.
And for this, we're building our deep dive on some truly exceptional source material. Two massive, multinational prospective cohort studies, known together as the TRDX study. We're talking nearly 3,650 patients, 31 leading hospitals, 6 different countries. This is the kind of robust, standardized data you need to finally cut through decades of, well, clinical confusion.
Okay, so our mission today is pretty simple. We want to determine for you, the listener, if that 10-centimeter number is a reliable, evidence-based standard. I mean, does 10 centimeters truly capture all the cancer spread, the lymph nodes, the vascular highway that feeds the tumor? Because right now, the global uncertainty on this is just massive.
Oh, that's putting it mildly. And that uncertainty leads to huge variations in care. So on one end, you have recommendations like those from the American Society of Colon and Rectal Surgeons, the ASCRS. They suggest a 5 to 7 centimeter margin. But then you look at institutions practicing what's called complete mesocolic excision, or CME.
That's the highly radical surgical approach, right?
Exactly. And with CME, some reports show the median resected length for, say, a left-sided tumor can be a staggering 38 centimeters.
38 centimeters versus 5. That's the difference between removing a couple of inches of tissue and removing well over a foot. That divergence just tells you everything you need to know about the lack of standardized evidence. Until now.
It does, and a big reason for that massive swing comes from, a lack of agreement on how to even define regional lymph nodes, or LNs. So to be clear for our discussion, we are really focusing on pericolic nodes.
Okay, and what are those exactly?
Those are the lymph nodes located directly along the bowel wall and the marginal artery. We have to know how far along the bowel those crucial nodes actually spread to make sure we get them all.
So to standardize the surgery, you need definitive mapping. Let's jump into the methodology of the TREX study. Why did this one succeed where others maybe fell short?
Well, the rigor is what makes it so powerful. You see, previous studies were often retrospective.
Looking backwards.
Right, looking backwards at old tissue samples. Samples prepared by pathologists who weren't necessarily focused on measuring lymphatic spread with, centimeter-level precision.
So what was the innovation here?
It was perspective, planned from the start, and conducted in vivo.
Which means?
During the operation itself, before the specimen was even removed from the body. The surgeons, they were following a very strict protocol. They physically marked the bowel wall with tiny serosal sutures at specific measured distances from the tumor's edge.
So they're literally sewing little markers onto the bowel in the operating room.
Exactly. At 3, 5, 7, and 10 centimeters from the tumor margin. And in the expanded cohort, they went even further out, marking at 15 and 20 centimeters.
And this lets the pathologist know exactly where to look.
Precisely. The pathologist gets this specimen with clear, labeled sections. They can examine the lymph nodes in Zone A, then Zone B, Zone C, and so on. It lets them pinpoint the exact location of the most distant metastatic lymph node.
That sounds like an incredible amount of detailed, coordinated work between the surgeon and the pathologist, just to get that level of granularity.
It was a monumental effort, but it gave us data on actual anatomical spread that we've just never had before. And just give you a sense of the scale, across the whole cohort, they retrieved and examined a mean of 20.9 pericolic nodes per patient, a massive validated data set.
Okay, let's unpack this then. With all that meticulous mapping, what was the definitive finding? The core question, can surgeons really rely on that 10-centimeter rule? Is cancer frequently sneaking past that marker?
Well, the finding is resounding, and it fundamentally validates the 10-centimeter standard. Pericolic lymphatic spread, so cancer cells moving through the lymph channels right along the bowel wall spread beyond 10 centimeters from the tumor was, it was incredibly rare.
How rare are we talking?
We're talking 0.2% of patients.
0.2%. So that's 7 patients out of nearly 3,650.
Exactly.
It's essentially a non-event in 99.8% of cases.
Precisely. The data just strongly suggests that for the vast overwhelming majority of patients, the local lymphatic spread is fully contained within that 10-centimeter radius. So for you, the listener, this means the 10-centimeter mark isn't some arbitrary rule of thumb. It's a really oncologically sound boundary.
But let me play devil's advocate here. If the risk is 0.2%, I mean, it's not zero, doesn't that slight risk justify extending the rule a bit? Maybe to 15 centimeters, just to be absolutely certain?
That's a fair and critical question. But that decision, it involves balancing a very marginal oncological gain against increased surgical complexity. The study found that those few exceptional cases, the 0.2%, almost always had advanced T3 or T4 tumors, often with massive lymph node involvement already.
And just remind us, what does a T3 or T4 tumor mean in simple terms?
T stage is about how deeply the tumor has invaded the bowel wall. T3 means it's gone through the muscle layer into the tissue around the colon. T4 means it's invaded other organs nearby or broken through the surface lining.
So these are already very advanced cancers.
Very advanced. And when you see that kind of distant spread in these cases, it often suggests that the cancer is no longer acting as a purely local disease. It's likely already systemic.
Meaning local surgery alone, no matter how wide the margin, might not be curative anyway.
That's the implication, yes.
Okay, so that brings us to the counterpoint. What happens if a surgeon, maybe following older guidelines, only uses a 5-centimeter margin?
The risk increases dramatically. If you use only a 5-centimeter resection margin, the incidence of LM positivity beyond that cutoff, I mean, we're talking about metastatic nodes that would be left behind in the patient.
Right.
That incidence increased significantly to 2.7%.
Wow. So moving from 10 centimeters down to 5 centimeters turns a near zero risk into almost a 3% risk of leaving active cancer behind. That's the crucial tipping point then, the difference between a curative cut and risking a recurrence.
It is the difference between an oncologically sufficient margin and an insufficient one. The data really makes it clear that the 10-centimeter rule is an appropriate and practical standard. It captures the essential local spread, and going wider, say, up to 20 or 30 centimeters, doesn't fundamentally improve the quality of the surgery for the vast majority of patients based on this anatomical data.
So wider doesn't automatically equal better cancer surgery if there's no detectable cancer to remove beyond that 10-centimeter line.
Exactly right.
Okay, so we've nailed down the length based on lymph node spread. But surgeons know it's not just about a ruler, it's about anatomy, especially the lymphovascular network. Which brings us to the feeding vessel. How does that 10-centimeter line up with the critical blood supply?
And this is where the study becomes this powerful synthesis of anatomy and oncology. The lymphatics, they follow the blood vessels. The nodes cluster around the blood supply. So the high-risk area for drainage is always going to be along the primary vessels that feed that tumor.
So what did the vascular mapping show? Did it line up?
It lined up almost perfectly. They found that in 99.7% of patients, the primary feeding artery was located in that paracolic region within 10 centimeters of the tumor. And this was true regardless of the patient's nationality or the surgeon's background.
That is just stunning confirmation. The 10-centimeter rule isn't just a convenient distance, it's an anatomical necessity.
And that's the proof, right there. It works because it ensures the complete en bloc excision of the whole high-risk unit at once. You're removing the regional paracolic lymph nodes, and you're removing the lymphovascular network leading back to the feeding artery's origin.
So if you resect less than 10 centimeters, you risk leaving part of that network behind.
You do. You risk cutting across that network.
Is there any scenario, then, where a surgeon should be cautious about sticking strictly to 10 centimeters?
Yes. There is one notable anatomical exception they highlighted: tumors located at the splenic flexure.
And where is that for our listeners?
It's a corner of the colon high up in the abdomen near the spleen, and it can sometimes have slightly unusual vascular branching. In about 2% of those specific splenic flexure cases, a slightly wider resection up to 15 centimeters was needed to be sure that the entire feeding artery network was included.
That's valuable nuance. It confirms the rule, but it also acknowledges that anatomy always requires surgical judgment. So we've established that 10 centimeters confidently covers the crucial paracolic area, the nodes right along the bowel. But that moves us to the real heart of the current surgical debate: central radicality. What about the deeper, more central lymph nodes that surgeons are targeting with a D3 dissection or a full, complete mesocolic excision? The ones that result in those huge 38-centimeter specimens.
This is where we have to get a bit more specific with the anatomy. We need to differentiate the lymph nodes. You have the paracolic nodes, which we just discussed. Think of those as level A, right along the bowel. Then you have intermediate nodes, that's level B, a bit further out. And finally, you have the central nodes, that's level C or D3. And they're located right along the main arteries that feed the whole section of the colon, like the SMA or the IMA.
And when a surgeon performs CME or D3, they are specifically going after those central nodes, right? To clear them out.
They are. The whole concept is that by removing the entire mesentery right up to the origin of that main vessel, you theoretically catch every single lymph node in the drainage basin. The question the TREX study really helps answer is that routine clearance necessary for every patient?
Okay, so let's start with the intermediate nodes, level B. Do they always need to come out?
Yes. The complete removal of the intermediate LNs, that should be considered an imperative surgical step. The risk of metastasis is just too high to ignore, even in early-stage disease. For T1 and T2 tumors, there's still a 2% to 5% risk of metastasis in those nodes. You just cannot leave level B behind.
Okay, but the central nodes, level C, closest to the main trunk.
Yeah.
That's the most debated area. What is the real risk of finding cancer there?
The risk stratification by tumor stage here is profound. Overall, metastasis in the central LNs happen in about 3% of the total cohort. But look at the early-stage tumors. Metastasis occurred in only 0.2% of T1 tumors and 1% of T2 tumors.
Less than 1% for early-stage disease.
Correct. But once you get into advanced disease, that rate climbs fast. It hits 3% for T3 tumors and a high of 7% for T4 tumors.
So the argument for routine, extensive central lymphadenectomy, a bigger, potentially more complex operation, is, well, it's severely weakened for those early T1, T2 tumors. You'd be subjecting 99% of those patients to an unnecessarily high radicality surgery for a tiny chance of hitting a positive node.
That is the clear implication. Now, the study does confirm that central lymphadenectomy is feasible. The 30-day mortality was remarkably low, only 0.1% for those level C procedures. But the data strongly suggests that the indication for it should be selective.
Selective based on the T stage.
Exactly. It is absolutely justified and potentially life-saving for patients with advanced T3, T4 tumors. But the data does not support it as a routine, one-size-fits-all procedure for low-stage disease.
So if we tie all this together, this huge international TREX effort really provides evidence-based, measurable standards where before we just had, regional preferences and massive variation.
It brings clarity and standardization. So let's quickly recap the major actionable takeaways from this for you.
Okay, takeaway number 1. The 10-centimeter rule is now proven. It's an internationally valid, evidence-based standard for the bowel resection margin. It is not an arbitrary measurement.
Second, that 10-centimeter margin reliably encompasses the vast majority, 99.8% of metastatic pericolic lymph nodes. And crucially, it captures the entire lymphovascular network associated with the feeding artery.
Third, going wider than 10 centimeters is rarely necessary unless you are dealing with a known anatomical challenge, like a splenic flexure tumor, where maybe 15 centimeters is needed to clear the vessels.
And finally, the value of that extensive central lymphadenectomy CME, or D3, is highly dependent on tumor stage. It's essential for advanced T3, T4 tumors, but the data suggests it's likely excessive for low-stage T1, T2 disease.
You know, this all raises a really compelling question for surgical practice globally. Given this anatomical consensus from prospective data, that 10 centimeter clears the essential area, if surgeons are still performing resections far wider than that, is that practice truly driven by oncological necessity? Or is it simply adherence to a traditional regional surgical philosophy?
And to build on that, the study noted a practical consequence. Increased radicality, especially at that central level, was associated with greater blood loss volume. And even if it didn't translate into more severe complications, it's still a factor. So we encourage you to consider that risk-benefit equation. Does that small increase in complexity and blood loss truly justify the marginal, almost non-existent benefit for the majority of early-stage patients who just don't have disease at that depth?
A profound thought on surgical precision and risk management to close out our deep dive. That is all the time we have for today. Thank you for joining us.